For the next 15 minutes, well, the true expert on prone positioning is, of course, Martha Curley, but I will try to act on her behalf. Prone positioning in pediatric ARDS. Well, my conflicts haven't changed over the past 30 minutes, so that's quite easy. This is, I think, has been alluded to in all the previous talks. Again, ARDS is a heterogeneous disease, and this is a dramatic chest radiograph that we can see in the unit. And if you would put the patient in a CT scan, you would see images like this, really dramatic overdistension, collapsed areas, really sick lungs. So the hallmark of ARDS, of course, is hypoxia and hypercapnia. And you have a combination in patients where they have shunt, so there's perfusion without ventilation. There is some ventilation without perfusion, which is dead space. And if you know this physiology schematic and try to put it on this patient, well, you can imagine what is going on in your patient. There is a dead space because there's overdistension. You have ventilation, but the capillaries are compressed. Normal areas and the shunt in the areas that are collapsed. And this all contributes to the hypoxia. And the hypoxia is further aggravated by the gravity. So here we have a patient. Patient is in supine position, ventral, dorsal. Here's the vertebrae, and there's a superimposed pressure. And if you go from ventral to dorsal, the superimposed pressure increases. And under normal conditions, there is a moderate increase, and the ratio of aerated versus non-aerated lung tissue is pretty well reserved, because otherwise we would be in problems when we go to sleep at night. But then we have the patient with the ARDS, and there will be edema, alveolar flooding, there will be inflammation, there will be destruction of tissue. And because of the edema, the lung will become heavier and the effects of gravity will become more prominent, and the superimposed pressure will be much stronger, and the ratio of aerated versus non-aerated tissue will negatively change dramatically, leading rise to a much larger degree of non-aerated lung tissue. And then if your patient is hypoxic, and I borrowed this slide from one of Peter's talks because I think it's a really fascinating slide. If your patient is hypoxic, consider turning the patient. And this concept was already tested at the end of the previous century, where they had a hypoxic patients, several patients, and they turned the patients from supine to prone positioning. And in almost all patients, they saw a dramatic improvement in the PF ratio, going from a PF ratio compatible with severe ARDS to PF ratios compatible with moderate or even mild ARDS. Also notable that not all patients were really important responders. So this was a first suggestion. And it's not only the oxygenation, but it's also the ventilation. And this is a really nice analysis of data obtained in randomized prone trials published by Luciano Gattinoni in Critical Medicine 2003, where they found that patients who had an improvement in PO2, and it was defined as more than 20 millimeters of mercury increase, if they put those responders versus non-responders in a logistic regression model, it did not really seem to impact the outcome of those patients. Whereas in those patients, if they stratified them by a response in improved ventilation, which was quite more than 1 millimeter of mercury decrease in CO2, they found that those who had a CO2 responders, they had a much better outcome than those who didn't respond in ventilation. So it's not only oxygenation that you might improve, but also ventilation. And if your ventilation improves, that is a strong indicator for a better patient outcome. And these were the numbers, because if you look at the CO2 responders and the oxygenation responders, you could see that the mortality rate in that group was 34%. But in a group who had a CO2 responders, but an oxygenation non-responders, the mortality was only slightly higher, 36%. But in those who didn't respond in ventilation, so in those patients whose ventilation wasn't improved, but the oxygenation improved, mortality was almost 55%. So it's the ventilation itself that also determines the outcome of those who are prone. Well, the first suggestion, it was not just the paper in 1997, but it was made much earlier. Again, in a paper from Professor Charlie Bryan from Sick Kids in Toronto, where they said, well, it's the devil is in the detail. And in supine position, there is a association with a volume deficit in the dependent parts of the lung. And anesthesia work was in line with this. So here you have a patient who is awake and spontaneous in supine position, then a anesthetized spontaneous breathing patient. But if you see in a paralyzed patient, there isn't a displacement of the diaphragm, the posterior part of the diaphragm, but it's more the anterior parts of the diaphragm. And what happens in a paralyzed patient, the volume is directed towards the non-dependent part of the lungs, thereby creating more overdistension and increasing the dead space. And in a patient who is breathing spontaneous, there is a direction of the tidal volume towards the dependent part of the lungs. This does not mean that every patient should breathe spontaneously. I think Professor Rimmelsberger really excellently showed the concept of patient self-inflicted lung injury in patients with severe lung injury. Spontaneous breathing may actually may worsen the situation rather than improving the situation. But this is the general concept of the prone positioning. If you have a patient who is supine, there's gravity and there's the weight of the heart. So here you have 4 CT scans of patients in a supine position, and in a supine position the area of lung below the heart is much larger than when the patient is in prone positioning, meaning that in a supine position there is a greater degree of lung tissue at risk for collapse due to the superimposed pressure. So with prone positioning, you get you flip the patient, there's still the gravity, but you get a better shape matching. And over time, in the end, you see that the lung aeration becomes more homogeneous across the lung compared with a patient who is in supine position. And this is nicely shown in this study from Gattinoni, where they calculated the gas tissue ratio in patients who were supine and then who were subsequently moved into prone after some time when the shape matching and the gravitational effects were accounted for. And then if you look in when they were in the supine position, let's take the ARDS patients, so these are the ARDS patients, though that in the non-dependent parts of the lung, the gas tissue ratio was greater and it decreased in the dependent parts of the lung, meaning that the non-aerated lung tissue was larger in the dependent lung zones, whereas in the supine, in the prone position, this was more or less homogeneous throughout the entire lung. So you get a better distribution of your tidal volume, and you get a better distribution of your transpulmonary pressure and shape matching when the patient is in prone. And we've heard a little bit about lung stress and strain in the earlier talk. And in prone positioning, there is a lower strain for a given transpulmonary pressure, so stress, when you are in prone positioning, the black bars compared with the supine positioning. So let's say if you even have had a large transpulmonary pressure for 30 centimeters of water, the strain is significantly lower in the supine, in the prone position compared with the supine position. And this effect stays the same if you would decrease the lung stress. So from a physiologic perspective, there is lots of suggestions that prone positioning should be implemented in your routine care. And it's not only the shape matching and the distribution of the transpulmonary pressure and the tidal volume, but it's also the perfusion. So this is an animal study where they found that when animals were who had lung injury induced by oleic acid, which is a really aggressive substance to cause lung injury, they found that when in the prone positioning, the blood flow was opposite compared with the supine positioning and improved compared with supine. So if you look at the dependent zone, there was a lower drop in the, there was a lower blood flow, but then of course that's where the heart is and where there is a lower lung area and more perfusion in the non-dependent lung zone. And in the same animal work, they found a effect of prone positioning on the pleural pressure gradient, which affects, of course, the perfusion. So this is a really nice study. And let's look at this graph. So here you have animals. It was a volume study, so we only look at the data before the infusion. So here you have the animals who were in supine position, here and you see them in prone positioning. And what they found that in the non-dependent zone, the pleural pressure became less negative, and in the dependent lung zone, the pleural pressure became less positive, meaning that overall the pleural pressure gradient became smaller in prone positioning, which would mean a more homogeneous distribution of the transpulmonary pressure. And this was confirmed in a healthy human model. So this is a human in supine position, and here you see the pleural pressure gradient, and you see the difference, and you see a strong pleural pressure gradient in the ventral parts compared with the dorsal parts. And then if that model was positioned prone, the pleural pressure gradient was more or less consistent throughout the entire lung. So there is a better distribution of your transpulmonary pressure. And there are many other effects. And if you look at the effects of prone patient positioning on respiratory mechanics in ventilated ICU patients, you would see that your end-expiratory lung volume increases, your resistance will drop or stay the same, your respiratory compliance will improve or stay the same, and that's mainly because the lung compliance improves, because the chest wall compliance, and that of course makes sense, drops because you flip the patient, chest wall compliance drops. Driving pressure stays the same, intrinsic PEEP will reduce, and oxygenation will improve. So there are a lot of mechanic benefits of prone positioning in ARDS. But again, this is the theory, and you have to match it with the experiment, and early work wasn't that really supportive of prone positioning, because Gattinoni showed in his paper in 2001 that indeed oxygenation improved, but if they looked at the survival, it was not different between the patients who were randomized to prone versus those who were randomized to supine. So there was no effect whatsoever. This is an all-comers ARDS. That's something that you should take note of. For pediatrics, the same. This is the one randomized controlled trial that we only have from Martha Curley, published in JAMA in 2005. But she also confirmed a strong improvement in PF ratio in those who were managed with prone positioning and a drop in the oxygenation index. But if she looked at ventilator-free days, which was the primary outcome, then there was no effect on ventilator-free days between supine and prone. So patients who were randomized to prone did not spend a shorter time on the ventilator compared with those who were randomized to supine. The question is, and it's probably the same question as with high frequency, should you use it for all patients or should you use it for those with severe ARDS? And if you want to use it for severe ARDS, we need to identify what severe ARDS is. This is the Berlin definition, the adult definition of ARDS. And this is the pediatric definition of ARDS, the PALIC definition. And in the adults, severe ARDS is defined by a PF ratio below 100 with a minimum PEEP of 5. For the pediatric version, it is defined severe ARDS as a oxygenation index equal or greater than 16, or if you don't have an indwelling arterial line, greater than 12.3. So maybe for severe ARDS, proning indeed improves patient outcome. Well, that thinking was more or less translated into this systematic review, where they stratified all the data that was out there on prone positioning by PF ratio in a group with a PF below greater than 100 or below 100. And in those with a PF ratio below 100, so compatible with the severe ARDS, there was a strong signal for a better outcome in patients managed with prone positioning. And for all other patients, this signal was statistically insignificant. So prone positioning should probably reserve for those with severe ARDS. Well, that finding was used by Claude Guérin in his landmark paper, randomizing adults with moderate to severe ARDS because he had a PF ratio of cutoff of 150. With greater P of 5 and FR2 greater than 0.6 in a multi-center study where they were randomized to prone positioning for at least 16 hours per day throughout 28 days. And what they found was a strong effect on patient outcome, a much higher survival in adults managed with prone. So the mortality dropped from 32.6 to 16%, and also 28 ventilator-free days at day 28 was much higher, meaning that patients who were randomized to prone spent a shorter time on the ventilator. So in adults, prone is, because of this study, is in all the concepts. The question is it only linked to the severity of ARDS? Because we see this systematic review with PF 100, but the trial, the Guérin trial, had a PF of 150 as cutoff point, or should we consider other aspects of lung protective ventilation into account, in particular the role of tidal volume? Because if you look at the trials that did not show because the trials that were studied, they had a tidal volume that was all over the place, going from 10 to 6 in the Guérin trial, with mortality all over the place. But they mainly found that in those trials who use low tidal volume, the effects of prone positioning were prominent. So if you are going to prone your patient with moderate to severe ARDS, it doesn't give you a carte blanche to use large tidal volume. You should still adhere to lung protective ventilation recommendations and use the lowest tidal volume that is allowed to allow for adequate gas exchange, because only then you can actually improve patient outcome. So if we know this and we go back to the Martha Curley trial, the only pediatric trial we have, the PF ratio, well, in the patients there was about compatible with what Guérin had included. So the baseline was around 150, but the tidal volume was, well, almost approaching 8, so a little bit higher than what you would expect in terms of lung protective ventilation. So where does this leave prone positioning pediatric ARDS nowadays? Well, I think Peter cited our study many times, how to manage ventilation. We have so many unknowns. Same goes for what is in the PEMVIC unknown. And if we look at what the adults have built in, again, for the part severity, increased severity, that at some point, if you have moderate severe ARDS, you should consider prone positioning or high frequency. Disclaimer, in our unit, we use first the oscillator, and then if the patient doesn't improve, then we move to prone. But I think there are many units where they don't have the oscillator. They would go to prone in case of oxygenation impairment, which of course is fine in line with this compatible. Proning has gained much interest during COVID-19. And many studies have been reported, and yes, in COVID-19 it does reduce mortality, even in awake prone patients. It doesn't reduce the need for intubation. So if you want to improve outcome, yes, but it doesn't avoid the anatracheal intubation on patients. Again, this is all adult data because there is very little pediatric data, unfortunately. Well, where are we now then with prone positioning at this stage? Well, PALIC, and this is the 2015 recommendation, and as Professor Rimmelsberger already mentioned, the revisions are currently underway and should be published hopefully this year. But in the PALIC, it is said, well, it cannot be recommended as a routine therapy in ARDS, but it should be considered in an option of severe ARDS. You could go moderate severe ARDS, and we need further studies. And that studies are coming. Well, this is the same study as I showed in the previous talk, the PROSPECT trial. And PROSPECT not only studies the effects of high frequency versus conventional, but also prone versus supine positioning. And we are also going to explore if there is any benefit of combining the two, so high frequency plus prone positioning. Well, patients with moderate to severe ARDS are randomized to either one of these 4 boxes, and then we are going to check our primary outcome, which is ventilator-free days, and the secondary outcome is organ failure-free days, and we are going to measure if there is an interaction between one of these boxes as well. So prone positioning improves oxygenation and outcome, especially in the context of severe ARDS, moderate to severe ARDS. There's no supportive data in pediatric ARDS, so routine prone positioning cannot be recommended at this stage. The Prospect trial is designed to study this, and I said I hope we can provide you with some answers over the next 3 to 4 years. But if at this time, if you want to use prone positioning, if you have a patient with severe ARDS and you've tried all other measures, and you don't have, for example, ECMO available, or you don't have an oscillator available, then I think you are really okay to prone your patient. And with that, I would like to thank you very much for your attention and give